Renu.
Hello, Declan.
I'm good. How are you?
I didn't ask you how you were, but I'm glad you're good. I'm good too. And it's 9:30 p.m. So it only means one thing, and it's time for another Bay of China themed podcast.
Yes. So welcome everyone to one of our special themed podcasts, which we hope everyone will enjoy them, but it's specifically for our many friends up in China, where every 3 months or so we do a dedicated podcast all about prostate cancer in China, supported by our friends at Bayer in China. We've been at this for a couple of years with the support of Bayer, and it's been really enjoyable because, of course, this stuff goes out on Spotify and Apple and YouTube, but also it gets pushed out on all the servers in China, and there's even a Chinese translation. So yeah, we're really
it's a great way to reach such a great population and spread the word and spread the message and learn from them, and we get to spread a little bit of education too.
Learn from them. Every single one of these China podcasts I do, and every time we go and visit China, boy do we learn, and the scale of stuff that happens, and
amazing.
The talent of the teams, the healthcare professionals in China never ceases to amaze me. So we're going to in a moment cross to our China editor Yao Zhu, who will be joining us again.
Absolutely.
Along with a special guest, we have Professor Yige Bao from Xiamen Hospital, who I'm really looking forward to chatting to, because I know he's a big fan of the podcast.
And I think he's already put in a request for some of our merchandise, so we'll be delivering it to him soon.
In person soon. And we'll get to that because we're going to have to talk about our next trip to China in a few weeks' time. But what are we going to talk about tonight, Renu? So ESMO, we've just had ESMO, haven't
still buzzing from ESMO, and unfortunately we couldn't make it in person, but you know we had plenty of highlights there, didn't we? It was a big year for GU oncology at ESMO.
Yeah, and actually non-prostate GU oncology was huge, wasn't it? Again, for the second year, bladder again.
Incredible.
Which we've talked about, but tonight we're going to focus on prostate cancer, and we've picked out 3 papers that we want to chat about. One of them was presented by our friend Yao Zhu from China, and he's going to summarize that for us briefly, and we'll have a discussion about it. This is about the impact of lead-in ADT onto docetaxel-induced severe neutropenia in MHSPC patients. This is a very interesting bit of work and got lots of attention at ESMO. Second, among the many MHSPC papers, there was a very nice post-hoc analysis that Fred Sad presented from the ARANOTE study, and this was really focusing on the different age groups and the impact of doublet therapy versus mono ADT therapy in men of all sorts of different age groups. So, you know, as it often is the case, isn't it, that real world practice is different to the median age group in a clinical trial. So that was very good. And then finally, PSMA addition, of course, which was in the presidential.
Yeah, absolutely.
And the use of radioligand therapy in MHSPC. So I know
presented
this is
by Scott Tagawa.
Who we of course we had a podcast.
Yeah, I didn't want
we had a full podcast. Yeah. So I'll put that in the show notes as well, actually. But it is exciting times in China for radioligand therapy, because lutetium 177 has just been approved and is about to roll out across China in the MCRPC setting, both post-chemo and pre-chemo. So therapy, vision, and PSMA4. So there are the 3 things that are coming up. But before we move to China to chat to Yao Zhu and Prof Bao, we are going to China in a few weeks.
We are going to Shanghai for the Fudan University annual meeting.
Yeah, Prof Ye's big meeting, KKGU, which always has a big host of international stars. We've always gone up there and interviewed many of the guests up there. So they've put on another huge meeting this year, and we're really excited to go up there mid-December or thereabouts.
Mid-December, straight, following ESMO Asia, in fact, in Singapore. Yeah. So 2 big meetings coming up for GUcast.
Yeah. And we'll be posting highlights from Shanghai a few weeks after. But ESMO Asia, of course, which you're very involved with, you're co-chairing the whole GU oncology.
I am, and Yao Zhu is on the committee with me, and so we've put in a lot of work to put this together, the GU stream, and it's looking fantastic.
Great, so let's do that. Let's pop up to Shanghai and welcome China editor Yao Zhu. How are you, my friend?
Good. How are you? Really glad to meet you, Declan and Renu. It's a wonderful GeoCast session, I believe.
Always good to see you.
And I'm very glad to invite my friend, Professor Bao from West China Hospital. He is a wonderful guy, and he is very enthusiasm about GU oncology. And I think today's discussion will be great and will be wonderful.
Wonderful.
Excellent.
Very
well, welcome,
good.
Bao. How are you?
Hi, it's a honor to be invited, and I have to say that I'm a big fan. I have been a subscriber for a long time for the GU cast, and it's a wonderful time for me to join here myself. And I'm sure a lot of my colleagues in China will be as excited as I am about when they see this program.
Well, look, before we dive into it, tell us a little bit about your hospital in West China. How big is your unit? Do you see much prostate cancer there? And tell us a bit about the region you live in.
Oh, yeah. So the region is in the southwest part of China. It's called Chengdu. It's an interesting place. It's the hometown of giant pandas. You can see pandas everywhere in China. It's just in the southwest part of my home. So be sure to visit Chengdu sometime with your family, with your kids.
Yes, we're just
I'll be sure to give a great, wonderful treat with the giant pandas. You guys will love it. So
oh my gosh.
the hospital has been there for a long time. It's called the West China Union University. It's been established back in the 1902 by the Canadian and the American missionaries. So it basically starts at the right beginning of the modern medicine being transported into China. It's been a long history, and now it's one of the largest hospitals in China, hosting more than 3,300 beds. So we got a Department of Urology with 150 beds and about like 1/3 being the GU oncology. So it's a relatively high volume center, and we do taking care of lots of prostate cancer patients. Our annual prostate cancer patient volume is about 500 radical prostatectomy, and we've got about 200-ish new HSPCs per month. So it's a relatively high volume, and we hope we can use our volume to share more patient data to all of the colleagues around the world.
Absolutely. What a great overview. And you should be working for the local tourism authority.
You should, yeah. It's home to your hospital, but mainly to the giant pandas. That's the most important thing.
We want to go and visit already. So.
And can I ask about in your hospital?
Pandas.
Yes.
Wow, yeah. In your hospital, who takes care of the patients who come with metastatic hormone-sensitive prostate cancer? Is it the urologist, or is it the medical oncologist, or is it a combination of both?
Yes, it's an interesting question. I think that both the urologist and the medical oncologist would take care of the patients. And it basically depends on who the patient will be referring to. Mm-hmm. So the doctors who see the patient first basically takes care of the patient. But if the patient is receiving the platinum-based chemotherapy, it got to be into the medical oncology ward. If the patient is going to receive surgery, then it's the surgical ward.
Very good.
And if it's AR pathway inhibitors like darolutamide,
so doublet therapy, who would take care of that?
I think both the surgeons and the oncologists will love the darolutamide. It's effective, it's safe. Yeah, we love it.
Awesome. We love it. Okay.
Great introduction.
So let's dive into it. We'll spend a few minutes on each of these three topics. And first, we'll go to Yao Zhu and tell us a bit about this very interesting paper you presented at ESMO, this investigation into the impact of lead-in ADT on docetaxel-induced severe neutropenia. What is this all about, and what gave you the idea to study it?
Yeah, so we come to the idea of the effect of ADT on the metabolism of docetaxel from a very old JCO paper, which may be published a decade ago. The paper compares the docetaxel metabolism in patients with castration level of testosterone and those patients with normal testosterone level. And the paper suggests that the patients with castration may have increased metabolism and output of the docetaxel in the liver. So we come to the idea, maybe we could compare those patients with lead-in ADT therapy, and maybe we could evaluate the effect of lead-in ADT on severe neutropenia using the data of Arsons. So with this idea, we go to Bayer and trying to get the individual patient level data. And fortunately, we retrieve all these patients' data, and we analyze the patients who have leading ADT and those patients who have concurrent ADT with docetaxel. Mm-hmm. And the main finding is that patients with leading ADT, they have decreased level of severe more than grade 3 and 4 neutropenia in the first cycle, which very makes sense because patients in the second or the third cycle, they have both castrated level of testosterone. And we also suggest patients with 30 days ADT, they have a very significant decreased risk of neutropenia. So although this is a post-hoc analysis and our findings suggest leading ADT may decrease the level of severe neutropenia and it will not decrease the oncological outcome, which is very important. And we do not want the increased metabolism of docetaxel decrease the patient's outcome. And we think we could, with more evidence from the real world, we could validate these findings and provide a clinical suggestion to patients may have the risk of neutropenia, and we could give the patient ADT before the docetaxel administration and decrease his risk of neutropenia in the follow-up.
Wow.
Such a simple thing.
And so relevant, isn't it? Because when we're combining therapies and we're talking about doublet therapy, triplet therapy, sequencing becomes very important. And we always talk about sequencing from an oncological benefit point of view, but from a toxicity point of view, it's also really important. You know, does sequencing impact how much of these treatments they can receive? I think that's a really important question.
And severe neutropenia is such a terrible thing.
Yeah.
And it's 30 days. That was the number. So if men had started their ADT and waited for 30 days before they got the first cycle compared to start ADT and get the docetaxel like straight away within a few days, is that the difference? Wow.
Yeah. I think the median time for the leading ADT is around 20 to 30 days. So it's the time when the testosterone come to a castrated level. And for patients with concurrent ADT, it's often the ADT is given in a week with the docetaxel administration. So most likely the patient will have a high level of testosterone. So compare these two groups of patients.
Already
we think
castrate. Yeah.
And
yes.
I wonder, I mean, I know it's a post hoc analysis, but it's such a simple thing to do. You'd almost think, well, why would you not do that? Do you really need more data? I mean, if you're seriously considering a triplet type approach, or I suppose an old fashioned ADT docetaxel type approach, this would already be enough for me to say, well, make sure you get the patient on ADT for at least 4 weeks before you start the docetaxel. It's simple.
And what happens, Zhu, when you add the ARPs? So if you're talking about triplet therapy, and there are a lot of places where triplet therapy is a go-to in MHSBC. I mean, we tend to favor the doublet over the triplet, but there are a lot of places that go straight for triplet. How do you? I mean, the study hasn't been done, I guess, but how do you think the ARPI impacts on this?
Yeah, I think RP is a very important role in the triplet and doublet therapy. But regarding our study, we evaluate the main hypothesis is that testosterone impact the metabolism of the drug in the liver. And I think docetaxel, they have very little interaction with the darolutamide. So this is one benefit of the darolutamide. So we think maybe darolutamide has little impact on the metabolism of docetaxel, which makes, the comparison in our study mainly related to the testosterone itself.
Very interesting.
And simple.
Very
I love it.
good.
I've learned something, and a very nice piece of work. And
you know what? Congratulations, because it never ceases to amaze me the quality of work that comes out of Fudan University. So again, fantastic paper and congratulations.
Yeah.
Thank you.
Bao, can I ask you, out in West China, what is the interest in triplet therapy? Because now I suppose we have, with the data out of ARANOTE as well, meeting its primary endpoint, the doublet has always been more attractive to many of us, thinking, well, hang on, if we're already going to use a doublet, we're going to have ADT and an ARPI, what's the point in adding in docetaxel when we don't have evidence that adding the docetaxel helps? But what's it like in your center? Is there still enthusiasm for triplet using ADT, ARPI, and docetaxel, or will people prefer just a doublet with ADT, ARPI for most patients?
Well, yeah, I mean, chemotherapy is always going to have a role in the treatment of prostate cancer. And on the other hand, there were always some patients being afraid of the word chemotherapy.
Chemophobia.
And some urologists afraid of the word too.
So yeah, I mean, like both trials would definitely have their wonderful role in the real world practice, right? Like for me, like just as what said in the Arisons, when there has been like high volume, high grades, high risk diseases, for sure, like there is definitely going to be some role with the triplet therapy. And for me personally, besides those high volume diseases, if there are patients that is harboring, let's say, certain gene mutations and RP or PTEN, so I'm probably going to more into the ethic of talking patients into the triplet therapy, and sometimes I tend to look at the dynamic of the drop. Like if it doesn't really decrease that well in the first 2 or 3 months, that's also something we can talk this into, and that's why I think Dr. Zhu's work is really wonderful. That sometimes you can basically wait a few 1 month or two before the chemotherapy kicks in. That's actually a wonderful timing. So that's also one of the times that we can talk to the patient about the chemotherapy. On the other hand, just like the trials we're going to talk to, like there are some fragile, old patients that chemotherapy may not be an option. And meanwhile, if the doublet therapy is also effective and safe, I mean, why not? It's a safe and stable treatment combination, and we don't want to kick patients into the ICU because of like severe bone marrow depression. So I mean, yeah, it's wonderful. The only thing that comes into my mind is that if you look at the cohort of those 2 trials, the patients actually have some combination of their trials, right? Even in the Aranome, like there are a decent amount of patients that has grade Gleason grade 8 or high volume or high grade. So it's actually wonderful that if you think about those things, similar cohort of the patients that actually can generate positive results in the 2 different designs. So yeah, I mean, I personally love the trial, and I think a lot of Chinese patients is also going to be very happy that they're going to get an extra option on how their disease can be treated.
Excellent. What a great summary.
Very good, yeah.
Okay, let's go to our second one. So this is the one I mentioned that Fred Sad presented on behalf of other Aranote investigators. And it was, again, looking at Aranote, a post hoc analysis. So reminder, Aranote was the pivotal randomized trial of ADT alone versus ADT plus darolutamide. RPFS was the primary endpoint that read out positive. So now that's licensed and regulated and licensed all over the place. Including here in Australia.
Actually read out in ESMO last year. So.
Yes, it did. Yeah,
we
met Fred over there. Exactly.
Right.
And so we've had this here in Australia for a number of years, actually, because, of course, we had it with Arisen's data. But curiously, in Australia, when it was approved here based on Arisen's, we were actually allowed to use it as a doublet as well. So there was a fair amount of darolutamide real-world data in the doublet setting in anticipation of the positive endpoint for Aranote. But anyway, this post-hoc analysis is actually addressing the issue of, is there a difference in the age groups of the patients? So while the median age across the whole trial of 670 patients was 70 years of age, we're always wondering, what about that, older patient, for example, comes in with MHSPC, and they had patients into their 90s in this study as well. So the purpose of this analysis was to see, was there a difference when you split these into different age groups? So the age groups were, first of all, under 65 years of age, and that was 27% of the population. There was between 65 and 75. That was the biggest group with 43% of the population. There was patients over the age of 75, which is 29%. And that included 4% of patients over the age of 85. So the questions were, number one, what was the RPFS like in this population? Was it different between the age groups? And second, what about tolerability? And put very simply, what it showed was that the hazard ratio held up in all the age groups, the younger men and the older men and so on, with no significant difference. And all the secondary endpoints, the FACT-P and the tolerability were all exactly in line with what was already presented. So the older age groups benefited just as similarly as the other ones. And what about the incidence and severity of adverse events? Well, these increased a little bit with age, as you would expect, but it was similar for placebo. So, in the placebo arm of the trial, as men get older and a bit more frail, they also had the similar side effects. So yeah, it was a nice summary from Fred saying in all age groups, darolutamide showed high efficacy with a positive impact on quality of life and minimal burden of TAEs. So I suppose, Renu, we were chatting about it before we hit record, weren't we, about those older patients. And in Australia, we certainly have quite a lot of older, fit men. And we put them through our multidisciplinary team meeting. If I've got a 89-year-old who's really fit with MHSPC, we put it through the MDT to say, is this an ADT monotherapy patient? Do we need to intensify? And what I've, very much people will turn around and say, well, tell us about the patient. Is he active? Yes, he plays golf or maybe
cycles a bit, travels around Europe.
Exactly. But of course, if it's a very frail 89-year-old, I'm not even going to bring it into the MDT. We're going to, but it's certainly reassuring.
Absolutely. I mean, and again, this is real world scenario, right? I mean, you do have these patients, and you think, well, doublet therapy has really become the new standard of care rather than ADT monotherapy. But age is often used as the excuse.
Yeah.
So I think studies like this, it's nice to see that men who are fit in the older population still benefit and still have very minimal burden of side effects.
Don't be ageist, she says. Now, look, a caveat is these men all had to be fit for a clinical trial.
Yeah.
So I think of these older age patients, they were fit for a clinical trial as well. So we have to take that into it. And of course, many Asian patients in are not, which is also reassuring. But Yao Zhu, what's your thought on this? You have lots of very fit Chinese men as well. What's your approach, I suppose, to doublet or intensification treatment in the older patients?
Yeah, I think this study is very important. It's given very strong evidence, although it's post-hoc analysis, give very strong evidence to suggest the decision to doublet treatment is not or really influenced by the age itself, because in the GU community, especially for the urologists, we sometimes have the impression that patients with young age, they may have aggressive cancer and more suitable for the doublet treatment. And some patients with old age, they may have indolent prostate cancer, and they may well suit for the ADT monotherapy. However, from the post-hoc analysis of the Aridot trial, we clearly see the benefit of darolutamide in patients with old age. So this is a very strong suggestion that we should suggest the patients to treat it with doublet treatment based on the detection of metastasis in the workup of prostate cancer, not only solely on the age itself. So I think it's a very strong indication and a strong evidence to promote doublet treatment in patients with old age.
And especially with darolutamide, because I think darolutamide already has a reputation for being quite safe in the elderly population. And I think analysis like this do kind of stamp that further, that, if you do have a reasonably fit older man with metastatic hormone-sensitive prostate cancer, well, don't discount doublet therapy as the standard of care in this man still.
And Bao, how do you assess the older patients? Do you use any sort of validated frailty scores, or are you a bit like me? I just eyeball the patient and get a sense of, do I think this patient is going to tolerate doublet? And I agree with you. I mean, you have to look for reasons not to offer a doublet nowadays. But how do you approach the older man who comes in with his family? He's just been diagnosed with MHSPC. He's got a lot of bone metastases. Let's say he's 88. But he's still active, but maybe he walks with a stick and he's got a few heart problems. And you've done the checks to say he can have ADT. But yeah, what do you do?
Yeah, like on the clinic, I usually ask my student to do a quick ECOG score. But yes, Dr. Murphy, I strongly agree with you that, experienced physicians always got gut feelings. When you eyeball the patient, you will know if he's a good candidate or not. And from my perspective view, I mean, the trial is a great trial. I mean, it reminds me of those car commercials. Like, if you want to show how good your car is, you just put them into blizzards, extreme conditions, and the car still performs good. This is an extreme test for the darolutamide, right? The oldest patients still safe. So that's the reason why I love Aranose and Aracins. In Aracins, it basically tells you the combination of chemo alone with ADT does not exist anymore. So it's always going to be triplet therapies. And for the Aranodes, I think the ADT alone would not exist. Everyone should go to the duplet therapy because it's safe. Even for the oldest patient, it's safe. So why ADT alone? So I mean, I loved the ideas about how those trials could resemble those meanings. Though there have been discussions about like the control arm may be a little bit weak for those trials because there has been a decent amount of the high grade, high volume disease, and the control arm is ADT only. But if you consider there has been so many old patients, then you will know the ADT only control arm actually makes sense. So I think the old the cohort is actually a perfect resemblance of how those darolutamide could benefit patients in this cohort.
The oldest patient that I've put on a doublet, I'm thinking he listens to the podcast as well. He's a retired anaesthetist. He was 92 when I put him on 2 years ago when I put him on ADT and darolutamide. But he's got a rowing machine in the garage. Okay, so if you're in your 90s
and weights
and he is fit and I think that sort of patient with quite high burden MHSPC. Why not? And he's done really well. He came in to see me for his 2-year checkup recently. So yeah, I mean there are some exceptional people, but I mean, it's not all exceptional people in a trial like this. And it's fair. These people have a spread.
I do think that in the elderly patient, if you deem them not to be fit for an RP, well, are they even fit for ADT?
You're correct. That's a good point,
that's
isn't
the crux
question.
of it.
Yeah. Okay, awesome. Very nice. Well done to Fred Sad and co. Fred, who's been in the studio as well, of course, a number of times.
Absolutely.
And then finally, PSMA addition. Of course, I mean, that was in the presidential, so the big plenary.
Big publication and a podcast.
They got the whole thing. Actually, the publication isn't out yet. They haven't they haven't published the paper yet, but we did drop the podcast as soon as the embargo released.
Lifted,
and I should say also there were other prostate cancer papers at ESMO, but they were in the more advanced setting and the less advanced setting rather. So we had non-metastatic readouts from EMBARK and also from ENZARAD. So
that's
two interesting ones, but we're focusing specifically on metastatic disease for this one. What about PSMA addition then? So pivotal trial, 1,100 patients, phase 3 randomized. This was a study of patients who were being started on ADT and an RP, plus or minus add in 6 cycles of lutetium PSMA with RPFS as the endpoint. So it got into the presidential. Scott Tagawa read it out. Our colleague Arun Azad did the discussion from Peter Mack. And it was a positive trial. The data was a hazard ratio of 0.72 for RPFS in favor of the patients who received lutetium PSMA. And overall survival, of course, it was too early to comment on that. Overall, across the subgroups, the RPFS benefit was there for all these patients. But it was interesting. It was when it was read out and Arun did the discussion, people made a few comments, didn't they? One of the comments was, do we really need to give 6 cycles in the MHSPC setting? And Arun showed during his discussion a patient of ours from the upfront PSMA trial that we presented at ESMO last year, who after 2 cycles, like the scans look totally normal, the PSA is undetectable. So there's a question of, is that a bit of over-treatment? Do we really need to spend 6 whole cycles of radioligand therapy on that group? And second, there were questions about quality of life, because although there wasn't I think they described it as not a clinically significant deterioration, nonetheless, the scores were down a little bit. So it did provoke a bit of reaction, but nonetheless, positive trial, presidential, big paper will come soon. And I think it's anticipated that it will, get FDA approval as well, because it was designed in conjunction with the FDA. It met its endpoint, and there's a lot of crossover. 70-80% crossover. So it won't reach overall survival probably because everyone, when they progress, was getting lutetium. So Yeah. What's your thoughts?
I mean, super interesting trial. You know, when upfront PSMA read out, we knew that the standard of care in prostate cancer had really changed. I mean, it's no longer ADT and docetaxel; it's now ADT and ARPI. So this trial is very relevant. But you know, the 6 cycles thing, it's something that's just been adopted from the MCRPC setting, and we know from trials even like ENZA-P that you can tailor the number of treatments to the way their scans respond, because we can see where the treatment effect is taking place. So I think that's very relevant going forward. You know, do not expose these patients to unnecessary toxicity when you can really tailor treatment to what is happening on the scans.
Exactly right. So, Zhu, what are your thoughts on it? You've long had an interest in PSMA imaging and then theranostics. What do you think of PSMA addition?
Yeah, I think it's a great study, phase 3 and international randomized trial. And I think when we move the lutetium PSMA to early stage disease, we should more focus on the precision selection of patients who are most likely to benefit from the addition of radioligand therapy. And I will compare PSMA addition with the upfront PSMA. And from upfront PSMA, I totally agree the points you just mentioned. With only 2 cycles of radioligand therapy combined with docetaxel, more than 40% of patients will become PSMA undetectable at 48 weeks. So it's quite remarkable patients with only 2 cycles of radioligand therapy with high volume disease and high uptake of PSMA really benefit from radioligand therapy combined with the conventional standard of care. So to me, I think more than about half of the patients may not most likely to benefit from radioligand therapy addition to the AIPI. So how to select the patients most likely benefit from the 6 cycles of radioligand therapy will be a very interesting point to be discussed in the future. And I also like the idea to double PET PSMA combined with FDG in patients. I think it's not only the go or not go decision tools in radioligand therapy, it also grades the patient from the most likely to benefit to moderate benefit. So it's quite an interesting tool to select the best treatment for individual patients. So I like the idea of selection and individual dose when we move the radioligand therapy to the MHSPCCT.
And this is really a huge area of expertise for you, Zhao, because you know you've done a lot of work on biomarkers, and so biomarker selected patients, especially in the MHSPC space, perhaps you know include imaging biomarkers, like you say, both PSMA PET-CT and FDG PET-CT. I think that's really important in making sure that the right patient gets this treatment.
Yes, I totally agree.
Totally. And Bao, we'll leave the last words on radioligand therapy to you. Do you have any experience yet of lutetium PSMA in prostate cancer, or is your hospital getting ready for the upcoming approvals around China?
Yes, we got some pilot patient trial data, and I mean it's definitely effective, and I'm a big fan of the radioligand therapies. So as you just mentioned, we actually just get approved last week about the lutetium 177 PSMA trials in China, both before chemo and after chemo. So it's a big day in China. So it's actually great that we were actually talking about PSMA addition trial today. I mean, it's an interesting trial. Everybody's talking about that. And I mean, it's selecting the ADT plus ARPI as a control arm, so it's a solid, strong, standard control arm, which is good. And with those control arms, you may worry that the overall survival may not be as easy as to become statistically significant. So I think the trial designer is actually pretty smart. There is a huge amount of crossover, so overall survival doesn't matter that much. If we can reach progression-free survival, then it's a positive trial. It's set the PFS as the only primary outcomes, which is not that common in the MHSPC trials if you think about that. In the only other trials I can think of that uses the PFS as the only primary outcome is the ARCHES. The other trials, I think the Latitude, Titan, Peace-1 is basically setting PFS and OS as the core primary endpoints, while the charted GTAC, Enzamet, Arison, I think is the overall survival as the primary outcome. So I think it's a great trial, great study, good choice of a good selection of the primary outcomes. And I think when it's been utilized in the NHSPC, the toxicity, we should consider more about that. My potential concern about the radioligand therapy is its toxicity might not be exactly the same as docetaxel. I mean, for the docetaxel, when you stop it, it's gone. The patient will recover very quickly. So for the radiotherapy, I was concerned that they might have long-term bone marrow suppressions. So I don't know how long it will recover. Would that have an impact for the subsequent chemotherapy? I don't know. So we probably need to stay watch on that for a little bit long time. For the overall survival, I mean, still immature. You can see a lot of sensory points and the end of the survival curve. So we're probably going to need to wait a little bit long. But as Dr. Zhu mentioned, how many cycles were good, we don't know. In the urothelial carcinoma, there is a trial called Discuss. If you just use half of the number of the cycles, it could still be working. So I don't know if that's the same case for the radioligand therapy. But yeah, there's a huge potential. But I mean, it has opened a new door to a new world. The radioligand therapy still can have a role in the HSPC. I think that's the most important thing we can learn from the trial.
Yeah, great summary.
Very,
It's
very
always going to be the
points.
concern bringing it forward into early disease, like we did with lutectomy. That is there going to be, even in a tiny group of patients, a price to pay with late toxicity within the marrow? But overall, it seems good, doesn't it? But I think outside the US, I still think the mainstay of treatment for the coming years will be in CRPC setting, won't it? We're not going to be getting reimbursement here in Australia for that in the without OS and stuff. We haven't even really got the pipeline running for CRPC yet, but yeah.
But I mean, I think that's an important perspective you bring, Bao, because you're saying, well, are we ruining their chances to get chemo later on?
Yeah.
Well, it's a good thought, and perhaps why we should be cautious in using multiple cycles straight away up front without some way of gauging what the effect is.
And, when Louise Emmett presented the adaptive dosing data in ENZA-P, reassess after 2 cycles and all that, this is very pragmatic. And I think a lot of people will look at that to say, well, if you were redesigning something like PSMA addition again, you definitely would be doing that. You'd be building in, reassessments and probably stop, and that's probably what we took out of upfront PSMA, as Zhu said. And also the other thing is from a cost point of view, and it may well be, okay, add in those 2 cycles like we did in upfront, get some sort of significant benefit, but, keep the money in the bank as well and say, well, maybe because we re-challenge patients all the time, as Zhu knows from coming here. We've now got patients, they've had up to 20 cycles over many years of lutetium because we've been doing it for 10 years. So, it might be worth keeping it until your CRPC and then let me have 2 more cycles then,
And again, Zhu, some of your
affordable.
sequencing work might come in handy here because, again, what we can learn from trials like ENZA-P is that if you pre-treat these patients with an ARPI, you get upregulation of PSMA receptors, and then perhaps those 2 cycles of lutetium PSMA will go a lot further.
I love it. We have come to the end of our ESMO highlights for those 3 papers. I really enjoyed that. Did you learn a bit?
I learnt a lot.
Yeah. You're still thinking about the giant pandas though, aren't you?
That's all I can think about, the giant pandas. I want to come and visit you, Bao.
Yeah,
See
me
the
too.
giant panda. I love it.
I love it. Great. And
No
look,
wonder you guys are smiling all the time.
well, look, we're pushing this episode out at the end of November, but then in December, ESMO Asia is on in Singapore, and again, you're on you're co-chairing the GU stream, so we're looking forward to that, and we'll be seeing many of our Chinese friends there. And then I'm going straight to China to do some speaker tour work on radioligand therapy, actually, and then wind my way to Shanghai for CACAD GU. We'll see both of you guys there and many of our other friends, and we'll see our friends from Bear China, We're going to have our studio there like we did last year. We're going to have a big
stay
studio
tuned for
set up.
lots of content coming up.
Yeah, and Bayer China also support all our conference highlights. So we've got a program lined up for ESMO Asia as well, where we'll be chatting to people in
We've got
Singapore.
a great turnout in ESMO Asia. Michael Hoffman will be joining us there. James Buteau.
Yeah, Arun
Great
Azad.
turnout. Arun Azad, yeah.
So, gents, thank you so much for joining us. That was a cracking episode. Again, thanks to our friends at Bayer China for supporting these China special episodes, and they are committed to doing it again all of next year. So we look forward to more episodes next year. Yeah, we look forward to bringing more highlights over the next few months.
See you soon.
Gents, thank you so much.